red light comes on, and then we'll start blinking. That's the end of the 5 minutes. So we'll use this instead of my wristwatch. And our first speaker this afternoon is Kim McCleary.
As many of you know, my name is Kim McCleary, and I'm President and CEO of the CFIDS Association of America. And I'm grateful for this timely opportunity to address members of the CFS Advisory Committee, the ex officio agency representatives, and the public. I believe I hold the unique distinction of having attended every single meeting of this committee and its predecessors since they were first opened to the public in 1993. And I have to say that this morning's session was the best session I've ever attended of this committee, and I extend gratitude to Dr. Jones for inviting Dr. Peterson and Dr. Coffin to address the committee and the public about the very important work on XMRV. A lot has happened since that first meeting in 1993, and at the same time, too little has happened. In fact, a lot has happened since the last meeting of the CFSAC in May, and again, too little has happened. Since 1993, a few facts have been documented beyond dispute. CFS is a very real condition, and it seriously affects the lives of millions of people worldwide who have it and people who love them. CFS is complicated, whether it's caused by a retrovirus called XMRV or as the result of multiple genetic and environmental factors, including one or more agents acting together. It has defied explanation now for a quarter of a century. But what we knew in 1993 and what we know today is that we need more research. We need better medical care. We need more people, especially doctors, to understand and to care about CFS. And what has stumped this panel of CFS experts and all of us who've taken part in advocacy over the years is how to mobilize our federal resources to accomplish those things. There is now the scientific momentum to fuel that mobilization. Notably, the NIH has participated in the XMRV research through the National Cancer Institute's intramural program, and the NIAID has made a recent grant to the WPI to support expanded research on XMRV. NCI Director Dr. John Nieberhuber has reiterated his institute's support of continuing research on the topic and to understand the relationship of XMRV to human disease, including CFS and prostate cancer. He's also provided very helpful interim guidelines at the association's request to help patients, family members, and the public while research expands. In addition, the NIH's Office of Research on Women's Health collaborated with us last month to host a meeting of funded investigators at the Cold Spring Harbor Lab, with the outcome of unparalleled consensus that a formal research network linking CFS investigators would propel the field through enhanced communication, establishment of best practices, and implementation of standard operating procedures for CFS studies. The XMRV research and many of the issues that were discussed in the afternoon session after lunch could be immediately enhanced if this network were operating. Yet we're moving forward to implement the recommendations arising from the Banbury meeting and to create this network. And in the meantime, the association, like WPI, is helping to coordinate with researchers in the US and other countries who have a genuine interest in replicating the XMRV research. In spite of this very recent progress, as is noted earlier today, NIH funding for CFS is actually at the very same level it was in 1993. There are many avenues of scientific investigation worthy of NIH support, and it is important not to lose sight of the many body systems affected by CFS that warrant continued study. We urge the CFS Advisory Committee to recommend that NIH immediately issue an RFA to capitalize on increased interest in CFS research arising from the XMRV publication and the promise of a formal research network. 6 months ago, when this committee met, the CDC presented a draft five-year strategic plan. And earlier today, Dr. Miller reported that having received almost 1,200 items of correspondence about its draft by July 30th. The final version distributed today incorporates some welcome additions, including recognition that the empiric criteria should be reevaluated as the foundation for CDC's research. However, the repetitive emphasis on psychosocial features, risk-conferring behaviors, and chronic unwellness reflects a disregard and or dismissal of the major criticisms of the draft plan that were loudly and plainly echoed by organizations and individuals at public meetings held in April, May, and in written correspondence. I'm reminded of the first public meeting of the ICC in 1993 that was held in Atlanta, at which federal agencies of existence by eliminating the 11 symptom criteria and focusing solely on chronic fatigue. Nancy and Dan and David will remember that meeting too. Now this CDC plan threatens to impose a similar death sentence. We implore the CFSAC not to let this go, to aggressively challenge the plan and protect the hard-earned progress of the last 16 years. Let's not waste that $25 million that should fuel important research. In conclusion, the federal resources being applied to CFS must catch up with the magnitude of this condition and must at least match the proportion of private investments made by WPI, the CFIDS Association, the IACFS, and other organizations over the years. The momentum is building, and the time to solve CFS is now.
Thank you, Kim. The next commenter is Sarah Turner, and while she's coming up, I did forget to note that we have learned there have been about 400 hits on the webcast throughout the day, so hats off, helping us get the word out, and clearly shows the level of interest in this meeting, so that's terrific. Okay, Sarah Turner, please.
Good afternoon. My name is Sarah Council Turner. I'm 36 years old, and I've been sick for 3 years. My illness started with what I thought was the flu. I went to a doctor who ran various tests on me for about 2 months. All that time, I tried to keep working full-time, thinking I would be better soon. Finally, after using up all my sick days, I tried to apply for short-term disability, but the doctor refused to sign the papers because she still didn't have a diagnosis. She blamed me, saying there must be something I wasn't telling her, and if I really felt that bad, I should go to the emergency room. Thankfully, my next doctor was very different. She helped me file the disability claim by listing my symptoms and noting that she was still running tests to find the cause. She tested me for Epstein-Barr virus and diagnosed me with mononucleosis. Putting a name to my illness helped put my mind at ease, even though there was no medication for it. I went on leave from my job and fully expected to be well in no more than a few months. 3 months later, I went back to work. The plan was to start part-time and gradually ramp up to full-time over 6 weeks. Instead, that process took a full year. Every time I tried to increase my hours, I suffered a setback. Finally, I did start back full-time. I was able to keep it up for 6 months. Then I had a relapse. I went on leave again for another 3 months. Up to this point, I had been calling my illness chronic Epstein-Barr virus and thought of it as a lingering form of mono. But last October, my doctor changed my diagnosis to chronic fatigue syndrome. When I came back in January of this year, I really tried to get back to full-time again, but I just couldn't do it. Finally, in June, my job was officially changed to part-time status. I now work 3 days a week. Sometimes even that's a lot. Sometimes I work from home. But thanks to the patience and good faith of my employer, the arrangement is working out for now. The most difficult part about living with CFS for me is that it's so unpredictable. I don't know when my symptoms will flare up and when they will subside. Every morning, I guess how much I'll be able to do that day. Sometimes it's hard to tell, and I have to make tough choices. Should I go to work, hoping to be able to put in a whole day? Or should I stay at home, hoping the rest I get will be worth the cost of being out again? The other big challenge has been negotiating with doctors and insurance companies. My doctor is sympathetic, and she believes that my illness is real, but she knows of no treatment beyond rest and gentle exercise. She's not curious about diet or alternative healing methods, so I've had to do my own research and try things myself. I have found some results with yoga, integrative manual therapy, and a gluten-free diet, but trying these things is always a shot in the dark. Until recently, I would have had nothing bad to say about my disability insurance. The system worked well for me, and the benefits helped pay the bills. However, my claim was suddenly closed at the end of August, and I'm now in the process of filing an appeal. This has been particularly frustrating because the reason they gave for closing my claim is that they say my doctor has provided no medical evidence that supports my not being able to work full-time. On a daily basis, I try to avoid wasting energy on what could have been if I weren't sick. But the fact is, this illness is taking away a big chunk of my life at a time when I expected to be moving ahead in my career and starting a family. It's not easy to face the possibility of losing my job, or worse, of never getting well enough to be a mom. So here's what I've got. I have faith in God's goodness. I have a wonderful husband and a solid network of friends and family, and a very helpful CFS support group, and an employer who's willing to work with me. I have some limited relief for my symptoms through diet, meditation, light exercise, and other non-medical interventions. So I have the resources to deal with being sick right now. What I don't have, and what I'm asking from you, is a way through this illness and back to health. Please make research leading to objective diagnosis and treatment of CFS your highest priority. Please do all that you can to fix the way private disability companies deal with CFS in their policies and handling of claims. And please continue to educate doctors so patients won't be blamed for their illness when they try to get help. Thank you for your time.
Thank you, Ms. Turner. And let me announce again as well that those of you presenting today in person, if you have not sent your comments in written form to the CFSAC mailbox or brought them with you today, we would like to have them to be able to put them up on the CFSAC website as part of the proceedings. So we're very grateful for that. And so are those who wish to see what you have to say. Stacy Stephens. Is Stacy here? Very good. Oops.
I'm a former member of this committee. My name is Stacy Stephens, and unlike David, I do not have hives, so I'm pleased to see you all. I would like to express my gratitude to those serving on the CFSAC now and in the past who have given of their time and their expertise. Despite your good work, there has not been a written response from Health and Human Services to a single recommendation of this committee since 2003. This is unacceptable and must be changed. That said, I give credit to those ex officio members who have acted courageously in moving forward with recommendations from the advisory committee. For those of you who have done so, I thank you. CFS is a physical disease, and we can identify, characterize, and measure its most distinctive and disabling features. The gold standard in medicine is to identify and employ objective measures to evaluate disease and illness severity. That is what we do at the Pacific Fatigue Laboratory, evaluate multi-system function and impairment in CFS. A medically determinable impairment requires objective evidence. For example, we have developed an objective serial cardiopulmonary exercise testing protocol using AMA guidelines that measures functional impairment, as well as metabolic, cardiovascular, and pulmonary systems, both at rest and during exercise. This protocol elicits and measures both fatigue and post-exertional malaise, considered to be a hallmark symptom of CFS. By contrast, the CDC recommends the use of self-report questionnaires to diagnose and quantify this illness. Questionnaires simply do not provide the evidence required by the Social Security Administration or long-term disability carriers to diagnose medical illness or determine a disability claim. That questionnaires have become the standard of diagnosis for CFS at the CDC shows how little progress they have made in the last 25 years in characterizing this disabling syndrome. The questionnaire approach to diagnosis in CFS at the CDC has also been criticized by psychiatrist Eleanor Stein, the IACFS Emmy ambassador from Canada. As she was unable to speak today, she asked me to read the following statement. I would like to express my strong concern about the harm being done by using the 2005 empiric definition of CFS. This definition recommends diagnosing CFS using 3 self-report questionnaires. 2 of the 3 are nonspecific and erroneously include people with a wide variety of disorders, including primary psychiatric problems. It is obvious to me as a dedicated CFS clinician that I cannot use the empiric definition in good faith in my practice. I rely on the FACUDA and the Canadian consensus definitions for diagnosis and all medical legal issues. The empiric definition has resulted in a dramatically increased prevalence in CFS in the US. Studies by Jason and colleagues have shown that this increased prevalence may be due to the inclusion of persons with depression. Without a sensitive and specific case definition, how can future research hope to uncover the biomedical underpinnings of this disorder for the benefit of those who suffer? It is my hope that the CFSAC will make a public statement that the empiric criteria should not be used for either clinical care or research, and that until a better definition is created, the FACUDA and/or Canadian consensus definitions be used. In conclusion, given the lack of progress at CDC, the CFS Advisory Committee's #1 recommendation from their last meeting was to establish new leadership at the CDC for the CFS program. This recommendation was in concert with those made by the IACFS and CFIDS Association of America. Yet this unified call for change from the 3 most respected organizations in the field has gone unheeded. We have objective measures. We have discernible physical characteristics. It is well past time for the CDC to become responsive to the researchers, clinicians, and patients who are united in their insistence on objective diagnostic criteria rather than self-report questionnaires to characterize this disabling illness. Thank you.
Thank you, Ms. Stephens. Fred Friedberg.
Okay. As president of the International Association for Chronic Fatigue Syndrome, I thank the CFS Advisory Committee for this opportunity to present testimony on behalf of my organization. 6 months ago, the 3 major CFS scientific advocacy groups, the IACFS, the CFIDS Association of America, and this committee all recommended new, open-minded leadership at the CFS research program in the Centers for Disease Control. We commend this bold and important action by the CFSAC. Despite this unprecedented consensus, the CDC has shown no indication of changing its CFS program leadership. This is surprising given its track record to date. After 25 years and over $100 million of CDC research, chronic fatigue syndrome remains a stigmatized illness without substantive progress on public health policy or objective diagnosis and treatment. And their new 5-year, $25 million plan fails to inspire any confidence that change will occur. In fact, the consensus recommendation of these scientific advocacy groups was based on dissatisfaction with the CDC's ill-conceived and impossibly far-reaching 5-year research plan. President Obama said in his inaugural address, "The fundamental question of our time is not whether government is too big or too small. It will be whether it works. The CDC is the World Public Health Authority. It can certainly provide more effective leadership in this poorly understood domain." I am speaking not only for my organization, but for several prominent biomedical scientists whose opinions should be considered in our ongoing efforts to effect change. These individuals were unable to speak today. Gudrun Lang, a member of the Distinguished External Review Panel that in 2008 evaluated the CFS program at CDC, asked me to read this quote. I am very disappointed that CDC has not been more proactive in implementing important suggestions made by peer reviewers. The committee recommended that CDC, as the lead health agency dealing with CFS, establish closer relationships with other traditional public health agencies to further promote CFS as a significant health concern. This includes using broadly disseminated public service announcements. In addition, it is rather surprising that CDC has not shown any initiative to address obvious research questions posed by the H1N1 epidemic. Why are we not surveilling the population for post-infectious fatigue following H1N1? Distinguished UK geneticist Jonathan Kerr expressed the following. Research output on CFS from the CDC in the last 5 years has been principally in the areas of gene expression and mutation. These studies used patients who did not attend CFS clinics and were not diagnosed by recognized CFS clinicians. A microarray was utilized which did not represent the entire human genome, yet such an array was available at the time. Also, the microarray gene profiles were not confirmed using real-time PCR, a standard procedure because the arrays are sensitive but not very specific. The findings of these papers do not lead anywhere and were not followed up by CDC. They do not provide insights into pathogenesis, nor do they indicate candidate treatment targets. Recommendations. Although the CDC program has ignored the views of scientific advocacy groups, their CFS program will not go forward without a challenge. We ask the CFSAC to support us in our ongoing efforts. We respectfully recommend the following. A continuing critical focus on the CDC chronic fatigue program during this and subsequent meetings until the leadership is changed. A new scientific forum at the CFSAC that allows biomedical scientists who wish to speak at the meeting the opportunity to do so. This is important because prominent scientists and clinicians who attempted to register to speak 3 weeks in advance of this meeting were waitlisted. Permission for non-US biomedical experts in CFS to participate in these scientific forums. They are not permitted to speak now. Given that there are so few CFS experts worldwide, we need informed views to make informed recommendations. If we, the CFS scientific community, remain united in common purpose, we can lead the way to major new public policy initiatives and research programs that advance the recognition and understanding of this still poorly understood illness. Thank
Your
you.
5 minutes are up.
Thank you.
Thank you. Harnoor Singh. Is Harnoor Singh here? Okay, we will move to the next person on the list, Hillary Johnson. No, we had to update because Court had yielded his. Are you retracting your yielding, Court? Since you were originally on the list, come on back because we did have no response after you told us you were going to withdraw and the replacement person has not identified themselves, then you can resume your original spot.
My testimony is presented on behalf of Dr. Charles Lapp of the Hunter Hopkins Institute in North Carolina. This is his statement. Many of you know me as a former member of the CFS Advisory Committee and also know that I have specialized in chronic fatigue syndrome since 1985. Only a handful of doctors have provided diagnosis and management to as many patients as I have. My patients complain that their illness is not accepted by either the public or their providers. They feel humiliated, ridiculed, discredited, and frustrated. Friends and family dismiss their illness, and doctors are either unwilling to or are incapable of managing their problems. On the other side of the coin, my fellow practitioners are frustrated by an illness that is complicated, has no visible signs, no diagnostic marker, and has long been regarded as psychiatric in nature. Treatment guidelines are published for many illnesses. The CDC has published the Provider Toolkit. However, the toolkit guidelines are too simplistic, nonspecific, and outdated. Some recommendations, such as cognitive behavioral therapy, are downright impractical. Exercise advice is spotty and incomplete. Only 1,704 providers, an alarmingly small number, have requested copies of this printed material. Specific and practical guidelines for the management of chronic fatigue syndrome need to be developed, updated regularly, and made widely available in print and web-based formats. I was honored to be one of the authors of the Provider Project sponsored by HRSA, the CDC, and the CFIDS Association. From 1997 to 2007, we developed a course that Lenny Jason and I taught to primary providers. We educated 77 providers, who in turn taught 2,300 other colleagues. The self-taught module was requested by 8,800 additional providers. This was